gastric bypass is one of the commonest laparoscopic procedures that is done for bariatric surgery all over the world. The advantage of laparoscopic Roux-en-Y gastric bypass is that it is not only a malabsorptive procedure but also a combination of restrictive procedure along with malabsorption. During the procedure, what we do is to gain access into the abdominal cavity, we make multiple small incisions, may vary from 5 to 6 in number, and using trocars we gain access into the peritoneal cavity. Once we enter into the peritoneal cavity in total is examined and the feasibility of the surgery is confirmed. Once the feasibility of the surgery is confirmed, the upper end of the stomach is made into a small pouch, and this creates a restriction of food by allowing only a small quantity of food to be consumed at one time. Then once the pouch is created using endo-GI staplers, the small intestine is transected at a distance of normally about 50 to 70 centimeters from the ligament of Treitz or the duodenojejunal junction. The distal end of the transected small intestine is brought up and is anastomosed to the small pouch that is created in the stomach. This can be done either by using a hand-sewn suturing, a linear stapler, or a circular stapler. There are various methods of doing this. Once we do this, the proximal end of the small intestine is anastomosed again to the distal limb at a distance of about 100 centimeters. So what happens is, in total, when a patient takes food, the food passes without coming in contact with any digestive juices for about 150 to 200 centimeters, depending on his BMI and the comorbidities that he is suffering from. Beyond the 200 centimeters, the biliary and the pancreatic juices, they come in contact with the patient, with the food that is ingested, and the digestive process begins there. This is what is a gastric bypass procedure. Band surgery, a tunnel is created in the retrogastric space just behind the stomach, in the upper portion of the stomach, and the band is introduced through one of the trocars used for the instruments. This band is passed inside and is brought retrogastrically through the tunnel all around the upper portion of the stomach and is locked with the locking mechanism that the band has. Once the band is locked, then the tubing of the band is brought out under the skin, and the injection port is attached to this tubing of the band. This injection port is used to insufflate and desufflate the band so that the band can be tightened or loosened. The advantage of this is by tightening the band, we can create more restriction, and we can by loosening the band, we can reduce the amount of restriction that the patient has. The advantage of this is that when a patient wants to eat more for any reason, like pregnancy or on a holiday or anything, the band can be desufflated, and when you need restriction to reduce weight, the band can be insufflated. One of the restrictive procedures in bariatric surgery, and is being very commonly done world over now, and especially in India. Here what we do is, the normal capacity of the stomach is about 800 to 1000 ml, and the food, as we all know, gets churned in the stomach before it passes down the intestine where it is digested. In sleeve gastrectomy, what we do is, using endolinear staplers, we transect the stomach into a small tube which is about approximately 2/10 of the actual size of the stomach, and the remaining portion of the stomach is removed from the peritoneal cavity. This tube restricts the intake of food at one time, and the tube allows the food to pass faster into the small intestine, and the portion of the fundus where the ghrelin is secreted is also removed in this surgery. So the satiety which is responsible for the satiety. So this procedure, the advantage of this procedure is there is no foreign body, and there is no malabsorption in this procedure.